Hi, and welcome to the August 2026 DermSurgery Digest podcast. I'm the podcast editor, Naomi Lawrence, Cooper Hospital, Rowan University. In this month's Spotlight podcast, focused on cosmetic and general dermatologic procedures, we have Kavita Darji Patel, a fellowship-trained cosmetic dermatologic surgeon in Southern California, doing the in-depth article summaries of key articles, and Dr. Gilly Munavalli, who is the medical director and founder of Dermatology Laser and Vein Specialist of the Carolinas, as the senior expert editor with commentaries. In this month's segments, the article summaries will be available only in the audio format. Don't forget that we will continue to offer Beyond the Digest, a podcast covering articles focused on dermatologic surgery, but outside of the Dermatologic Surgery Journal, and At the Microscope, a quarterly publication that is topic focused on histopathologic content relevant to dermatologic surgery. All of our episodes are typically available in video format on the ASDS YouTube channel. Thank you for listening and have a happy surgery day.
Hello, everybody. My name is Dr. Kavita Darji Patel. We will be covering today the cosmetic articles in the August issue of the Dermatologic Surgery Journal, starting with the article titled, "Does Hormone Replacement Therapy Influence Melasma Development? A Review of the Evidence and Management Guidelines." So I thought that this was a very interesting article. Very relevant to clinical practice, especially if you see a lot of patients with melasma.
Yeah.
Dr. Munavalli, do you have a large percentage of your melasma patients who are on high dose oral estrogen therapy or HRT in general? And do you tend to approach these patients differently based on that history?
I would say so. We do see a lot of melasma in our part of the country in the southeast, and we know that it affects a fairly high percentage of. There's a fairly high percentage, about 1% of the general population, but we also know that it's mostly in skin of color, and there's actually a fairly high hereditary component, or when you ask patients, they will tell you. So that's an interesting, and I do ask now. Melasma is tricky, as you know. It seems to me that in asking, we don't have a fairly high number that are on HRT currently, and when they are, it's kind of a good thing because it gives us an opportunity to easily intervene and see if that makes a difference.
Mm-hmm. Do you ever consider stopping that, or
So I will ask that. And if they're able to do that, I think that's great. I mean, the other thing this article doesn't really discuss, it discusses different routes of administration, topical, oral. It doesn't talk about, to my recollection, IUDs.
Mm-hmm.
And I have had patients get flaring or develop melasma on progesterone only IUDs. So it's interesting. I mean, it's even though the article doesn't cover that, because one that might be an option if somebody's on oral and having an issue and it's really bad. The other thing I talked to them about is this sort of being a foreshadowing for what they might see when they get pregnant. It would be interesting to see that correlation, but I do have a fair number that'll say, yes, when I got pregnant, it was the same thing as, but yeah, if we could stop it, absolutely. We can change it. I don't typically make the changes myself, but I do
Right.
suggest they talk to their OB/GYN about it.
Interestingly, for high dose oral estrogen only HRT, in this article, case reports suggested an association to forearm melasma, especially in patients with Fitzpatrick types 3 to 6. Have you noted that at all in your clinical practice, or is it
I have
mostly?
not that correlation, but I have seen melasma in forearms. Again, we're in the southeast. We get a ton of sun here, and I've seen it in male patients on the forearms. Interestingly enough, and it took me a while to recognize it. Sometimes you think it's just photoaging when it's actually, it's actually melasma and can respond to some of these these topical therapies. So,
Right.
but I believe it.
Perfect. Any other points that you'd like to highlight that caught your
Yeah,
attention from this
I
article?
do. I think so. I know the lead author, the senior author, that is a really strong dermatologist and laser surgeon out of Australia, Dr. Lim, who has a lot of experience with manipulating pigment on the skin with lasers and energy-based devices. So, and has, I believe, has his own sort of melasma clinic because they see so much of it there. So, a lot of experience in this group, which I respect that. And what really came out to me is how little evidence we actually really have
Right.
on on this. Case reports, one small randomized, controlled trial. There's not a lot out there for us to sort of convince our patients about. We, if we can get them to stop it, we do. It's tough. I mean, as you know, melasma is cyclical, and we sort of approach it as something that we may not be able to cure, frankly. So we talk about how we vary our therapies over the course of a year, and year-to-year cycles. And so we tend to see these patients back fairly frequently.
I know that, the article briefly discussed treatment options, including sun protection, of course, chemical peels, and then cautious use of lasers.
Yes.
What would be your if you were to consider using lasers, do you have any go-to that you tend to prefer, especially in patients who have melasma?
Yeah, we're sort of a large laser referral center in the city and the surrounding area. And as such, we get some of these cases, and especially recalcitrant ones that don't really respond to topical. And one thing if I could speak to colleagues who are referring to us, I would say I wouldn't get patients' hopes up about laser. I mean, it's in most of my colleagues in the laser world, it's not first line therapy and
Right.
maybe not even second line therapy. We absolutely try to maximize topicals, maximize behaviors, and then when they come in, we'll look at that. And surprising number haven't had anything like that done. I mean, they haven't been put on. There's more of a movement now towards doing more high strength hydroquinone compounded agents, and those I found this to be very valuable. I mean, the age of oral tranexamic acid has changed everything with regards to how we but it always surprises me how few patients are even referred from dermatologists have even had that option discussed. But with regards to laser, uh, we will use typically or chemical peels because I think both can work great. It's low and slow, and so they have to understand that, for example, if I'm using either Q-switched or a picosecond Nd:YAG laser, which I tend to use, they're low energy toning treatments done over 2 to 3 week periods, and you might be talking about 6 to 10 treatments
Mm-hmm.
uh, to get some meaningful reduction along with the other therapies. The other thing we'll look at is there a presence of vascularity, and so if skin can tolerate pulse dye laser, that's a good place to start as well.
Perfect. Thank you. So that was a, very interesting discussion on this very relevant
It's a
article.
very good article. So.
Yes. Moving on to our next spotlight article titled The Effects of Aesthetic Lasers and Intense Pulsed Light on Skin Shields.
Mhm.
This was also a very nice article explaining a study, with various different lasers and the use of skin shields, laser treatment patches, silicon paper white tape, laser and IPL eye shields. Um, do you use any of these at all in your clinical practice for protection of, moles and tattoos,
Yeah.
etc.?
I mean, I'll say that the term of skin shields was something I wasn't aware of. That term, I thought it interesting. I do know that the treatment of pigmented lesions varies dramatically worldwide geographically. For example, in the article talks about, as you mentioned, and this is mostly out of the European colleagues, is protecting pigmented lesions, specifically melanocytic pigmented lesions, from some type of um, uh, change or potentially upgrading their, their dysplasia, or, even setting off some type of malignant transformation through exposure to laser or light or energy-based devices. And they have devised this way of protecting these lesions. Whereas in Asia, I mean, it's not uncommon to use Q-switched and picosecond lasers to treat dermal nevi, compound nevi, uh, um, uh, um, um, congenital nevi, all these things. They will use those, and they don't seem to have that worry. And they can be very sort of triggering cosmetic features in that patient population. So I understand the need to want to think about removing them. Have I ever seen a malignant transformation? No. Have I ever seen much in literature on it? Not really. So it was interesting to me for that standpoint. Now we do use eye shields very commonly.
Mhm.
And so if you consider this to be sort of an extension of that term, um, eye shields are very useful, and even eye shields themselves have changed. Say 10 years ago, they were a lot more useful because they had more adhesive on them than they do currently. And somewhere along the way, in the regulatory changes, they had to add more of the material that actually blocks the laser and the light, and less of the adhesive. So these actually become harder and harder to keep on there,
Right.
especially when patients are sort of wincing or animating from different procedures if they're uncomfortable. The more they do that, the more these things tend to come um, sort of unstuck. But I like the comparison. This is a group out of, I believe, out of UT Southwestern, and they do a lot. Their lead author or their senior author is very into laser safety, and so I get that this is an important topic. I'll use both the laser aids, we'll call them, or the IPL aids, and there's different brands, um, almost every day, both of them. And in fact, you have to be sort of careful as to look which one you're using. I
Mhm.
wouldn't want to use an IPL aid for a monochromatic, say, for example, Nd:YAG laser, right? If I can help, it's not designed for that.
Right. Which is what
Um,
my next question also was, or kind of the point that I wanted to highlight is that the article, suggested, and we practice this as well, but for the IPL shields for the 1064 Nd:YAG laser, it's not to be used.
Yes, and I agree with that. I mean, one of the classic clinical scenarios is periorbital reticular veins, or the sort of blue reticular veins around the eyes, of which the Nd:YAG, long pulse Nd:YAG, is very, very effective for. And you have options there. I mean, the eye shields, are like the skin shields, are one option, but corneal shields are another option. And I know colleagues and myself will probably not do this without the use of corneal shields, and even those, yeah, aren't super protective because that wavelength will bounce around the orbit and can impact, the retina. Even with those shields in place, it's been documented for hair removal.
Mm.
So you have to be super careful. But their comment about the YAG being potentially, not just a big no-no for using these shields is very well taken, because I know it's done quite a bit. It's just a lot easier to use those shields, and
Yes.
patients don't like corneal shields put in. They don't like the whole process. And heaven forbid it's a patient who's never worn contacts. It can take, it's a lot of work to get those shields in place sometimes. But this was very enlightening to me, because I could see the damage on these in some of the tests they were doing with the YAG. And
Yeah.
uh, I think this is it's a really useful article from the standpoint of laser safety.
Quick follow-up question on the Nd:YAG. Would you ever consider, if they're not using the internal corneal eye shields, metal external shields?
Yes, metal external shields are also very good, depending, but they can be sort of occluding to what you're trying to treat in two ways. I mean, if you've got these periorbital veins that are sort of near the margin of the lower lid, then it's hard because it'll occlude those. And also the straps can get in the way. You can actually uh, sort of lay them back and just rest them without using the straps, or hold them down manually.
Right.
I do like those as well.
Perfect. Any other points you'd like to highlight, or do you feel like we covered
No, I think the visual, the images, figures on this are very compelling. It just showed the
Yes.
injury, and they
Yeah.
mentioned the word, flammable or catching fire with some of these. So it's,
Yeah.
Yeah, it's a really good and interesting way of looking at safety of those.
Perfect. Great article on safety and efficacy when practicing lasers, and important for all clinicians and physicians who are using them.
I agree.
All right, moving on to our third and last spotlight article, which is titled, Does Cumulative Exposure to Overfilled Faces Cause Visual Adaptation? This was, I think, a very good article, simply because we see so much cosmetic enhancement, augmentation, use of lasers, fillers, injectables, and then, being able to see what medical professionals feel upon seeing a lot of these models. Do you feel that the exposure to the drift inducers, which were the 50 images of individuals who had undergone excessive aesthetic procedures that almost led to an unnatural appearance, how, any comments on that with regards to patients coming in and just kind of getting more and more done over the course of time?
Yeah, I thought it was interesting from several standpoints. I mean, and some of it depends on your sort of into how you practice, right? We have all across the board, even in our own field, we have colleagues that minimally fill, that sort of fill to proportion of what the features on the face are, and using different ratios, and I think that's great. And we have colleagues that overfill, and there's a lot of other aesthetic providers that have sort of entered in that are doing a lot of injectable treatments that don't quite have that level of training of that eye. And it if your patient comes in and gets a filler treatment and they don't feel like it's impactful enough, they may not come back. So there's some like sort of inherent bias of thinking, well, what can I do to make this person look like some? I think more and more people want to look like they've had something done.
Mm,
But we all see patients that come in that are frankly overfilled,
yep.
and that we would say, I would just think to myself, I just wouldn't do that.
Mm-hmm.
Uh, and I think there's a couple of reasons for that, even before we get to this. One is uh, there's a much deeper understanding of the longevity of how long these fillers actually last in certain parts of the face, the dynamic areas, non-dynamic areas. We've seen CT studies showing 8 to 10 years or longer that these fillers stay resident, if they're put deeper in the skin, and when they just come in every year, 6 months or a year, and they ask about it, and if you're inclined to keep using them, you're just adding more and more and more over time,
Right.
um, and on top of what's already there. So there's the aesthetic concerns, but there's all this concerns of, are we going to get an adverse reaction, which I think that's a whole nother discussion. When you do procedure on top of another and you may not clean properly, or you may have some reason which you've introduced something, patient may actually be sick or may have, yeah. So and then you've seeded what's there previously to cause a reaction. The other part of it is how sort of you wonder like how I, I truly believe that people get sort of uh, attuned to this. I mean, you wonder like how do some patients' friends not just say to them, maybe you should cut back, or family members, maybe you should cut back on this because you're not looking like yourself anymore. Have they become accommodated to that? Have you become accommodated to that? Looking in the mirror every day, we can't really tell sometimes. So this study was very interesting because it did look at professionals that do these treatments and studied gaze patterns of eyes to see where their eyes are drawn to.
Mm-hmm.
Uh, and does that give us sort of an idea that maybe, we are drawn to more overfilled areas, and we get used to it. And the conclusions were really interesting here in this article.
I agree. Something of note is that those physicians who had seen the female modified lips, they felt that those were almost more feminine, or kind of perceived a little bit more positively. Lips, patients come in for lip enhancement all the time. It tends to be one of the most popular procedures in terms of injectables. What are your thoughts on that?
Yeah, and it didn't used to be. It was interesting. I mean, for years doing fillers, that's the area we didn't really focus on as much. Or when I was training, we looked at how to maybe enhance the borders, and that would help with things like lipstick application, and maybe looking at some of the vertical lines around from dynamic movement. But I don't think the filler maturity of the products had really matured to the point where we could use them there like we can now.
Mhm.
So, and then we have a lot of choices in what filler, a lot more choices now on what fillers to use and how much volumization do we really need or do we really want? Um, and then there's the ethnic variety, which I think,
Mhm.
some ethnicities you just have much more full lips, and that translates into something that now maybe all other patients that aren't of that ethnicity can now have, and it can do it relatively easily. It's doing lip fillers is actually, as you know, pretty. It's nuanced, but it's not difficult to do. And so you get accommodated to that. And then the other part of it is that, volume loss in the lips, I think shows quicker, and it's a real phenomenon. And so
Mhm.
even if you're just keeping up with the natural aging process and volume loss, um, your eyes may not exactly see it that way, so.
Right. Interestingly, this finding was noted more so in female patients. In male patients, they described using more of a conservative approach
Mhm.
to prevent overfilling. Do you see a lot of male patients who desire lip augmentation in your practice?
No, not really. I mean, I could probably count on one hand in the past year how many male patients have been interested in that. They may be more interested in chin projections or the whole perioral uh, cosmetic subunit, if you would,
Right.
maybe some pre-jowl sulcus, jawline enhancement, chin definition. But in terms of the lips and maybe the commissures,
Mhm.
and maybe some of that can be handled with toxins because we get the platismal effect on pulling down on the lips cannot be underrated here because it can
Agreed.
cause it. But no, I don't. I typically don't see that in men.
Okay.
I haven't even been doing it, but with women, absolutely.
Right. Um, do you have any other points from this article that you'd like to highlight?
No, I just thought it was interesting that they would, we would this the authors had these, sort of predictions that the physicians would
Hmm.
you know, would see these, but they would pick out things more than others or find them to be unnatural. And in the areas where they didn't think it would be, it was like the cheeks, but in the lips, it was more tolerable. So it just sort of speaks to how our eyes look at things and, what attracts us.
Right. I'd be interested to see how this evolves over time. So,
Yes.
but
And
yeah,
then,
very interesting.
and it might be completely different in a different country,
That's true. Yeah. Even a different region, for example.
or a different region. That's right.
Okay. All right. Perfect. Well, thank you so much for your discussion on these spotlight articles of the August issue. It was a pleasure speaking to you about it, and I thoroughly enjoyed our discussion.
Thank you.
Thank you for listening to DermSurgery Digest, the official podcast of the Dermatologic Surgery Journal. To access these featured articles, author videos, and much more, visit journals.lww.com/dermatologic surgery. To learn more about the American Society for Dermatologic Surgery, visit asds.net.